Very good morning to all. Good morning to respected dignitaries, senior faculty members, my colleagues, and dear students. I, Dr. Shalini Garg, Assistant Professor from Department of Family Medicine, would like to take this opportunity today through the CCR platform to introduce you all to our department. First, let's understand what is family medicine, as it is a new, maybe a new term for some of you. Family medicine is a medical specialty which provides continuing comprehensive healthcare for individual and their family. It is a specialty in breadth that integrates the biological, clinical, and behavioral sciences. So, what's the role of family medicine in the healthcare system? It plays a crucial role as the first point of contact in the healthcare system, managing a wide range of conditions from acute illness to chronic diseases management and preventive care. Our approach emphasizes long-term doctor-patient relationship, health promotion, and early diagnosis. Our department was established at MGUMST in 2021. I feel proud and thankful to the management to start MD Family Medicine course, which was the first institute is the first institute in Rajasthan to start MD Family Medicine course, followed by AIIMS Jaipur. So what's our vision? The family medicine specialty and our department is dedicated in providing comprehensive and continuous care to all individuals and to develop a world-class department for excellence in education, training, and research. Our team includes experienced family physician faculties headed by Dr. Viren Kumar Gupta sir, residents and healthcare staff working collaboratively to deliver integrated and compassionate care. Our two MD students, after successfully clearing MD Family Medicine exam from our prestigious institute, are now very actively involved in promoting family medicine practice at their respective hometowns. Our OPD is situated at first floor, Sanjeevani block. Departmental work. In addition to the clinical services, like we approximately 1500 OPD we have seen last year in the last functional year. And we also are involved in medical checkups of our institute employees and outside faculty members. This excludes medical checkups and outreach camps. In addition to clinical services, our department is actively involved in medical education and community outreach activities, aiming to improve public health awareness and accessibility to quality care. At our department, we provide specialized care to all patients in a comprehensive, continuous, and coordinated way with other specialties in a more family-focused and cost-effective way. The basic philosophy behind the care is providing whole-person care in a patient-centered approach rather than the disease-centered. As I already told, we are very actively involved in the outreach OPDs. Now I will take you through our key achievements and ongoing initiatives. The first milestone achieved by our department was the conduction of our first batch of MD Family Medicine in October 2025, and we had 100% results. Our department is also actively involved in organizing academic activities. Recently, in November 2025, we organized a second state family medicine conference, that is FPCon Rajasthan, in our own institute, which was attended by more than 180 delegates, including renowned family medicine faculties across the country. We are thankful to our Honorable Emeritus Chairperson, sir, who graced the session as chief guest. Also, we organized a Yuva Josh program, which was a youth upliftment program aimed at overall well-being of students for undergraduate students, conducted by the eminent faculty from AIIMS Rishikesh and MGUMST faculty. Department of Family Medicine is also actively involved in organizing National Practical Exam Orientation Workshop. Annually, the first POS was conducted in February 2024, followed by the second in January 2025. We had more than 50 PG students across nation per workshop, and the key features were case discussion, station-based simulation, and hands-on training. So these are the glimpse of the first POS and the second POS. Not only in our own institute, but we as a department are actively involved in participation in other conferences. In FPCon Delhi, an RP session was taken by Department of Family Medicine. Our department regularly conducts academics in the form of seminar, case discussions, and journal clubs, and PG students are also very actively involved in paper and poster presentations at various state and national level conferences. Publications, till now we have done 15 researches, out of which 4, and also the 4 are ongoing with publications of more than 10. Faculty achievements. Dr. Viren Kumar Gupta sir, who is professor and head of our department, has been awarded with the Work Excellence Award by Indian Medical Association, and also chaired as a organizing chairperson for both PUS and FPCon Rajasthan. I myself was actively involved in academic activities at national and state level, and also serves as important position at state family medicine body. I'm extremely thankful to MGUMST management in giving me Work Excellence Award recently. Dr. Kanika Asaria, Assistant Professor in Department of Family Medicine, is also a very active fraternity in family medicine, and she was actively involved as a faculty and serves in a state executive body in Academy of Family Physicians of India, Rajasthan chapter. Last but not the least, our ongoing initiative. Recently, under guidance of Emeritus Chairperson Sir and Pro Vice Chancellor Sir, we started Family Adoption Program from 2026 onwards, which develops a holistic understanding of health, emphasis on preventive and promotive care, build patient-doctor relationship, and community orientation. So now I would like to conclude the introduction of our department. We'll start with a very interesting case today for today's CCR, a 33-year-old lady who presented to our family medicine OPD with dysphagia of 2-year duration. And for this, I would like to invite Dr. Yashowardhan Jain.
Thank you, ma'am. Good morning, honorable dignitaries, respected faculty, and my fellow colleagues. I am Dr. Yashowardhan Jain, PG resident from the Department of Family Medicine, and under the guidance of Dr. Virendra Kumar Gupta sir, Professor and Head, I would be discussing about a 33-year-old female who presented to us with complaints of dysphagia. The patient is a 33-year-old married female, homemaker, resident of Jaipur, living with her husband, child and in-laws in a semi-urban setting. She is graduate and functionally independent in daily activities. Primary complaint is difficulty in swallowing for 2 years. Additionally, she reports behavioral symptoms in the form of anger outbursts and irritability in the past 6 months. The dysphagia began insidiously 2 years ago. It was intermittent and non-progressive. It is more pronounced for solids than liquids. She describes a sensation of food sticking in the retrosternal region with delayed passage, often requiring water to facilitate swallowing. Her symptoms have increased in frequency over the past 6 months, though not clearly progressive. There was no history of difficulty in initiating swallowing, choking or coughing while swallowing, or decreased salivation. We performed Eating Assessment Tool 10, which is a quick and easy 10-item 5-point scale that captures swallowing specific symptoms and quality of life. Her score was 18, significantly above the cutoff of 3, indicating clinically meaningful dysphagia with impact on quality of life, which supported patient-reported symptom burden. To continue her history, patient reports of episodes of anger outbursts for last 6 months. These are characterized by sudden, disproportionate reactions of verbal aggression and occasional physical aggression towards her child. She retains insight into her behavior and experiences remorse post-episode. There is no history of substance use, any psychiatric illness, or medication contributing to these symptoms. In negative history, there is no history of coughing or choking, nasal regurgitation during swallowing, difficulty in initiating swallowing or decreased salivation, difficulty in opening mouth, any jaw pain or toothache, hoarseness of voice, vomiting, hematemesis or black stools, rashes, joint pain or swelling, or any corrosive ingestion. There is no history of prior GI surgery, radiation exposure, or chronic systemic illnesses such as diabetes, hypertension, or chronic connective tissue disorder. For personal history, she is vegetarian. Her appetite has decreased over the past 6 months, as earlier she used to have 3 to 4 regular meals a day, but now only has 2 meals a day and requires water after every bite and prefers mashed or liquid diet. Her sleep is disturbed with difficulty in initiating and maintaining sleep. Her bowel and bladder habits are normal and regular, with no addictions reported. She has undergone multiple consultations earlier, like ENT evaluation was done including flexible laryngoscopy, which was normal. Gastroenterology evaluation was also done, which included upper GI endoscopy with biopsy, showing only gastritis. A trial of proton pump inhibitors for 12 weeks was done, which yielded no symptomatic improvement. She is married for 6 years and her obstetric history is unremarkable, with one full-term normal vaginal delivery 3 years back. Her menstrual cycles are regular with no abnormalities, and she reports of pantoprazole and antacid syrup intake for around 12 weeks. In socio-economic history, she resides in an urban area, lives with her family including husband, child and her in-laws, lives in a well-ventilated pakka house with proper sanitation, clean piped potable water supply, and according to modified Kuppuswamy scale, her family belongs to upper middle class category. To summarize, we have a 33-year-old female who has difficulty in swallowing, feeling of food stuck in her chest for 2 years, episodes of anger outbursts, underwent flexible laryngoscopy and upper GI endoscopy, which came out to be normal, and past treatment failures. So what could be the possibilities? So, yeah, it could be.
Any comment on the weight?
Sir, around 1.5 kg weight was lost. It was non-significant.
Since the laryngoscopy and upper GI endoscopy is normal, sir, there is a possibility of esophageal motility disorder, which in this age mostly can be eclasia, but we need to do a manometry to.
And anger outbursts is like you've been emphasizing on that. Other than Dr. Swarnkar, who is spiritually very well advanced, all of us have anger outbursts. So how do you kind of, make it pathological versus physiological? Did you make any efforts
Actually,
to do
these
that?
outbursts were.
I can be very angry, no problem.
Why is she concerned with that? Very normal situation in the family setup.
So they were actually out of proportion to the trigger. Like a small thing made her angry, like that.
In the history, you feel that it is psychological.
Yes. So after thorough and detailed history, certain clinical possibilities were thought of. Depending on the complaint, they were divided into oropharyngeal and esophageal causes. Oropharyngeal causes were further divided into neurological and structural causes, neurological like stroke, myasthenia gravis, while structural like cervical webs, oropharyngeal tumors. Esophageal causes were also further divided into two, like motility disorders and structural disorders. Motility disorder like atlasia, diffuse esophageal spasm, and structural like esophagitis, stricture, hiatus hernia, etc. Few miscellaneous causes like avoidant or restrictive food disorder and functional dysphagia were also taken into account. After detailed history, the patient was examined.
जो आपका second main complaint है उसका भी तो DD बताओ ना. Abnormal anxiety or anger उसका DD भी तो बताओ.
And on general physical examination, patient was conscious to time, place and person, weighed around 55 kgs, height of 164 centimeters and BMI of 20.4 kg per meter square. Pallor, icterus, clubbing, cyanosis, edema and lymphadenopathy all were absent. Her vitals were within normal limits. Systemic examination was performed and in gastrointestinal system, her mouth, tongue and throat were normal. No dental caries were there. On inspection it was normal. On palpation there was no tenderness or organomegaly. Percussion and auscultation were also normal. For CNS examination, patient was conscious, cooperative and oriented. Her higher mental functions are intact and her sensory and motor examination were normal. Cranial nerve examination was done. It turned out to be normal with symmetrical face. There was no abnormal palatal movement or any tongue deviation or wasting. Her respiratory tract and cardiovascular system were also normal. A clinical swallow test was performed, which is an OPD or bedside based assessment to identify swallowing disorders by observing the patient swallow. She did not have cough or choke or had wet voice, or there were no signs of struggle with normal swallowing function, virtually ruling out oropharyngeal causes. Now to carry the case forward, I would like to call upon Dr. Nipun Sharma to discuss about the investigations of our patient.
In that anger outburst thing, did you interview the husband or the children?
Sorry, sir?
For the anger outburst, to confirm that, did you interview the
Yes, sir.
husband or
Yes,
the
sir.
children?
Husband was interviewed.
Good morning, respected dignitaries. I am Dr. Nipun Sharma, would be taking the case forward. Complete blood count revealed the hemoglobin of 10.5 gram per deciliter. MCV is at the upper limit, suggesting a macrocytic trend, while MCH is low. Other parameters including total leukocyte count, differentials, and platelets were within the normal limits. This points towards the nutritional deficiency state. Renal and liver function tests were done and were within the normal limits. Total protein and serum albumin were within the normal limits. Thyroid profile being normal, ruling out the hypothyroidism, which is a contributing factor to dysphagia. However, patient was deficient in vitamin B12 and D3 significantly. Chest X-ray shows no evidence of mediastinal widening, lung pathology, or any mediastinal mass lesion. Ultrasound abdomen was done, which was normal with no organomegaly or intra-abdominal pathology. These findings effectively rule out the extrinsic compression contributing to dysphagia. Upper GI endoscopy, as stated earlier, was done outside and revealed gastritis with no evidence of structural abnormalities such as strictures, ring, wabs, or mass lesions. This excludes the luminal obstruction as a cause of dysphagia. Now, as we have seen, patient was not having symptoms like regurgitation, coughing, and choking, and after examining the patient, oropharyngeal causes were ruled out. Given the patient's symptoms of food sticking in the chest, and esophageal causes were prioritized, including motility disorders and structural disorders. To assess the underlying cause of the dysphagia and to further evaluate the patient, she was referred to the Department of Gastroenterology, and I would like to call Dr. Samyak Jain from the Department of Gastroenterology to carry the case forward.
Thank you, Dr. Nipun. Good morning, respected dignitaries. Myself, Dr. Samyak Jain, a DM resident from the Department of Medical Gastroenterology, and I would like to take the discussion further for the evaluation of dysphagia. So, a quick clinical overview. So, we have a 33-year-old female with a 2-year history of intermittent non-progressive dysphagia, which was more initially to solid, and now she has dysphagia occasionally to liquids as well. She also complains of a retrosternal food sticking sensation in her chest. There was no history of any food impaction or complete obstruction. There was no odynophagia. There was no weight loss. There were no heartburn or regurgitation features, and there were no oropharyngeal features like choking, nasal regurgitation, and voice change. Other clues that the patient gave in history were that symptoms were variable and they were stress related. And general and systemic examination, as stated before, were essentially normal. So we can say that this is a young female with chronic non-progressive esophageal dysphagia without any alarming features. So as upper GI endoscopy and biopsy was done outside, which was essentially normal, patient was subjected to a barium swallow study. You can see that there is a smooth passage of contrast throughout the entire esophagus into the stomach. Pharyngeal recess, pyriform fossae and valleculae appear normal with no filling defects. The thoracic esophagus is normal in course, dilation, and there is no filling defect. And gastroesophageal junction is normal with no evidence of any hiatal hernia. Following normal barium study, the patient was advised for a manometric study. I would like to take a moment and express my gratitude to the chairperson and hospital administration for establishing a high-resolution solid-state esophageal manometry, which is the first facility of its kind in the state of Rajasthan, which enables us to do advanced evaluation of esophageal motility disorders. So a little bit about what is high-resolution solid-state manometry. So what it essentially is, it is a gold standard test for evaluating motility disorders in esophageal dysphagia. It uses a solid-state catheter which is inserted through nasal intubation up to the mark of lower esophageal sphincter. There are closely spaced sensors approximately 1 centimeter apart, and it provides a continuous pressure map of the esophagus. We can measure upper esophageal sphincter function and pressures. We can establish peristalsis, coordination and strength, And we can also measure lower esophageal sphincter strength and relaxation by measurement of integrated relaxation pressures by this. So it is essential in explaining unexplained dysphagia after a normal endoscopy, and it helps in ruling in and ruling out motility disorders such as eclasia, distal esophageal spasm, and hypercontractile esophagus. So the patient was subjected to a high resolution solid state manometry. This is a Klaus plot, which is a swallow composite of mean 10 swallows. So the patient underwent a total of 10 swallows, and this is a mean Klaus plot in which we can see that the upper esophageal sphincter relaxation, there is a transit of bolus into the esophagus, and there is relaxation of lower esophageal sphincter in the form of blue color. So the pressure was normal, and the study was essentially normal. So with structural and motility disorders ruled out, the patient was referred back to the Department of Family Medicine for further assessment of functional etiology. And I will now request Dr. Nipun from the Department of Family Medicine to kindly take the case forward. Thank you.
I would like to summarize the possibilities. 33-year-old female patient who has difficulty in passing food down, feeling of food stuck in her chest, complaints of anger outburst, normal general and systemic examinations, normal chest X-ray and ultrasound abdomen, essentially normal upper GI endoscopy with barium cello and high resolution manometry, reported normal. It meets the Rome 4 criteria of functional dysphagia, which include sense of solid or liquid food sticking or passing abnormally through the esophagus, absence of evidence of any mucosal structure abnormality, absence of evidence that GRD or any cause is causing the symptom, absence of any major motor disorder. So considering her anger outburst issues and esophageal eosinophilic esophagitis, considering her anger outburst issues and underlying psychological cause for her functional dysphagia, I would like to call upon Dr. Neil Joshi from the Department of Clinical Psychology to further discuss the case.
Good morning, respected dignitaries, faculty members and distinguished guests. I am Neil Joshi, Junior Resident of Department of Clinical Psychology, presenting today's case. The patient is a 33-year-old married woman who was referred to our department by the Department of Family Medicine. She was originally seeking treatment for difficulty in swallowing food, a physical complaint, but on psychological assessment, a far more complex picture emerged. She carries a provisional diagnosis of functional dysphagia alongside significant anger-related difficulties, which we believed are causally linked. Her presenting complaints fall into two broad clusters. The first cluster is behavioral and emotional: physical altercations with her husband, anger outbursts directed at her young child, low mood and excessive worry about her health. The second cluster is physical: numbness in the body, breathlessness, heaviness in the chest and difficulty swallowing food.
One is mostly physiological and
Sir, there is a importantly, these physical symptoms are not medically explained. They are the body's way of expressing psychological distress. The anger and relationship difficulties have been present for approximately 4 years. The physical symptoms have worsened significantly over the past 6 months and are currently on a deteriorating course. To understand how this patient reached her current state, we use a framework familiar to all clinicians: what causes a condition, what triggered it, and what keeps it going. She was predisposed by a family history of aggression in her grandfather and by inherited personality traits that made her emotionally reactive. Her condition was precipitated by marital conflict, discussions of divorce, and most acutely the deaths of two close family members in 2025. What keeps her symptoms going is the unresolved conflict with relatives, ongoing physical altercations with her husband, poor sleep, and continuing difficulty swallowing. The problems were first recognized at the age of 29. Now I will walk you through the history of how her difficulties developed over time. From childhood, she has been described as an irritable, short-tempered, and prone to aggression, not as passing phases, but as consistent traits. She physically fought with her grandfather on multiple occasions and with an exam invigilator during her class 12 board examinations. I draw the panel's attention to this early pattern. The aggression was present before any major life stressor. This is diagnostically significant as it points to a lifelong trait level difficulty rather than a reactive one. Two major turning points followed. In 2013, her grandfather, with whom she had a close relationship, passed away. She experienced what clinically resembles a depressive episode. Social withdrawal, low mood, disinterest in activities, and loss of friendships, lasting approximately a year. This is her first documented documented period of a significant psychological decompensation. The second turning point was her marriage in 2020. From the very beginning, conflict with her in-laws became a persistent stressor. She began directing her anger at her husband in the context of these family disputes, a pattern that has continued and intensified. The most critical event in this history occurred in March 2025 and requires careful attention. At a family wedding, a dispute arose when she refused her in-laws' demand regarding her attire. The situation escalated. She pushed her pregnant sister during the altercation, then fled to the terrace. By her own account, she felt an overwhelming need to escape and jumped from the second floor. She sustained injuries, lost consciousness overnight, and was hospitalized and discharged after 3 days. Following this event, her difficulty swallowing food worsened significantly. The year 2025 brought two significant bereavements in rapid succession. Her sister-in-law passed away in May due to hypertension. Her paternal aunt died in November due to a brain hemorrhage. Neither loss has been adequately processed. Most recently and most urgently, from a safeguarding perspective, she reports episodes of anger directed at her young daughter during moments of misbehavior, which have at times resulted in physical injury and bleeding to the child. This is an active concern that needs to be closely monitored. Alongside the behavioral history, we note that her mood is persistently dysphoric. She describes feeling sad from within with difficulty expressing it outwardly. She has withdrawn socially and lost interest in activities she previously enjoyed. Her biological functions have also been affected. Sleep is disturbed and she continues to experience difficulty swallowing food, which initially brought her to family medicine. Her family history is notable on two accounts. Medically, her paternal aunt died of a brain hemorrhage, a loss that is now also part of her grief. Psychologically, the family system itself is a site of dysfunction. Conflicts with her child, husband and in-laws are ongoing. Most significantly, she reports that she cannot control the impulse to harm her child, a statement that indicates partial insight and raises the level of risk in this case. The family has expressed concern about her temperament and more importantly about the child's well-being. Her personal history helps us understand the environment in which her personality developed. She grew up in a joint family where her grandfather was aggressive and short-tempered, yet this was never identified as a problem or addressed. In effect, aggression was normalized in her formative environment. Academically, she was an average student who completed a bachelor's degree in mathematics. She attempted police service examination but was rejected on documentation grounds. She described this as a deeply frustrating sense of injustice that fits a pattern we see throughout her history. She worked in a private bank as a loan recovery agent, a role that required being assertive and aggressive, and left due to family commitments after marriage, which she found distressing. Her marriage in 2020 was by her own choice. Conflict began early and remains ongoing. Physical altercations with her husband occur when he does not comply with her. There is also a note of deafness in one ear, which is a source of communication frustration. Her forensic history is noteworthy. She has 2 prior incidents of physical altercation with the board examination invigilator and with a bank client, both of which resulted in police complaints that were subsequently withdrawn. This reinforces the lifelong cross-contextual nature of her aggression. Before her illness became established, her personality showed features of independence and extroversion, strengths that we hope to build on in therapy. However, she also demonstrates that what we classify as cluster B personality traits. In simple terms, this refers to a pattern of intense emotions, impulsive behavior, and turbulent relationships that has been present across her lifetime and across multiple settings: home, school, workplace, and marriage. As we conclude the case history, we can conclude that there were no complaints nor history suggestive of eating disorders. In clinical psychology, we conduct a mental status examination, which can be seen as an equivalent to a physical examination as well. She was well kept and appropriately dressed. Rapport was established easily, which is a positive prognostic indicator. Her speech was relevant, coherent, and goal-directed. Her subjective mood, what she reported feeling, was sadness. She described it as crying from within. Her objective affect, what we observed, was euthymic, meaning outwardly she appeared relatively calm, though with a shallow emotional range. This discrepancy between inner experience and outer presentation is itself clinically meaningful. Continuing the examination, her thought processes were entirely intact, with no formal thought disorder, no perceptual disturbances, and no psychosis. However, her thought content was concerning on 2 points. First, she expressed worry about harming her child. Second, she described her somatic symptoms vividly: breathlessness, heaviness in the chest, difficulty swallowing, all of which reinforced the psychosomatic picture. Her judgment was adequate for personal and test tasks, but inadequate socially, which implies that she understands right from wrong in the abstract, but struggles to apply sound judgment in her interpersonal relationships.
So tell me, can you do this assessment on an objective basis or is it subjective?
It's generally done on an objective basis. Only the mood is done on the subjective basis. As we speak to the client, we get to know about the contents of the MSc.
Can be the organic causes of GI symptoms in a psychiatric patient?
Sir, the psychological stress causing bodily stress, the mind-body connection that happens.
I think you should take a history of eating of abnormal materials like spin needles and hair. So trichovezar is one of the commonest problems in such a patient, and that can present as GI symptoms.
That was ruled out.
I'm just asking the cause.
Her insight was graded at 4 out of 6. She's aware that she has psychological difficulties, but does not yet fully understand their origins or nature. This partial insight is actually an important entry point for therapy. These are the assessments which are planned as the patient continues to come for therapy. Based on the clinical picture, our first provisional diagnosis is intermittent explosive disorder, or IED, under ICD-11 criteria. In simple terms, IED is a condition characterized by recurrent episodes of explosive, disproportionate anger that goes far beyond what the situation warrants, is difficult to control, and causes serious harm to relationships and functioning. In her case, we see lifelong irritability and repeated physical fights, anger responses that escalate to violence over minor triggers, behavior clearly triggered by marital and in-law conflict, significant impairment in her marriage and with her child, and extreme high-risk behavior, including the March 2025 incident. Crucially, there is no history of mania, psychosis, or substance use, ruling out the other major conditions that could explain such aggression. Our second provisional diagnosis is personality difficulty with cluster B traits, again per ICD-11. This refers to a long-standing pattern present since childhood across all major life domains.
Can you explain cluster B traits? What are they?
Yes, this cluster B traits refers to a long-standing pattern present since childhood across all major life domains of poor impulse control, chronic anger, relational instability, and alternating between idealization and conflict in close relationships. Her repeated altercations at school, work, and home, her conflict with her husband-in-laws and child, and the impulsive self-harm attempt all contribute to this formulation. Now, IED as a psychosomatic factor, I want to draw attention to one key piece of research that is highly relevant for this particular patient. A 2024 study establishes that IED is not merely a behavioral condition, it has a direct and psychosomatic consequences. The mechanism is straightforward. Uncontrolled emotional dysregulation triggers a chronic state of autonomic arousal, the fight or flight response, which in turn produces physical symptoms, particularly gastrointestinal ones. This is precisely what we see in our patient. Her difficulty swallowing, her chest heaviness are the body's physical expression of a chronically dysregulated nervous system. Treating the psychological disorder is therefore not separate from treating the medical symptoms. Now I would like to invite Dr. Krishna Chandak to discuss the psychotherapeutic management.
Thank you, Dr. Neil. My name is Krishna Chandak, a senior resident of Department of Clinical Psychology. We now move on to the psychotherapeutic management, and all interventions are being delivered under the supervision of the respective faculties. Our approach is structured in two phases: an initial stabilization phase using focused individual psychotherapy, followed by a long-term skills building program. Our therapy goals are divided into short-term and long-term objectives. In the first few sessions, we focus on building her understanding of her condition, establishing her trust in the therapeutic process, and beginning relaxation training. In the long term, the goals are more ambitious: sustained anger management, the ability to communicate assertively without aggression, improved daily functioning, and ultimately relapse prevention. A particular priority is her relationship with her daughter. Improving her capacity to regulate anger in the parent-child context is both a therapeutic goal and a safeguarding one. The first session was devoted to psychoeducation, helping her understand what is happening to her and why. We explained what IED is: brief, explosive anger episodes that are disproportionate to the trigger and difficult to control. The link between unprocessed grief and irritability was also addressed. She lost 2 people in 2025 and neither loss has been worked through. Grief that has no outlet frequently surfaces as anger. We explained that therapy is a skill building process, not a quick fix, and directly addressed her ambivalence about seeking help. Patients with IED often believe their anger is justified. Building insight is therefore the essential first step before any skill can take hold. The follow-up visits moves us from understanding to doing. We introduced Jacobson progressive muscle relaxation. The reason for choosing this before anger management is physiological readiness. The patient's baseline arousal level is chronically elevated. IBS reflects a hyperactivated gut-brain axis. And when someone is in a state of persistent physiological tension, cognitive and behavioral skills do not land effectively. They cannot access the prefrontal cortex needed to implement them. JPMR works by directly engaging the parasympathetic nervous system, creating the neurological conditions for the skills that follow. She has been assigned home practice with audio guidance. Our long-term framework is dialectical behavior therapy. DBT is built on 4 pillars, each addressing a specific deficit in this patient. Mindfulness, teaching her to observe her anger before acting on it rather than acting reflexively. Then comes emotional regulation, building the capacity to identify, name and modify emotional states before they escalate. Distress tolerance, which is also very significant in her case, developing skills to survive intense emotional moments, particularly grief, marital conflict and anger at her child, without making the situation worse. And lastly, interpersonal effectiveness, learning to express needs, set limits and resolve conflict in ways that preserve rather than damage relationships. Now I would like to call Dr. Nipun to take over.
Thank you, Dr. Krishna. Now we'd like to discuss about the pharmacological management that we have started in our patient. So after thorough and detailed evaluation and assessment done, we came to our final diagnosis of functional dysphagia as per the Rome 4 criteria, with underlying cause being intermittent explosive disorder and cluster B personality traits. In the pharmacological management, we have started the patient on SSRIs, that is selective serotonin reuptake inhibitors, in which escitalopram 10 mg was started along with the clonazepam 0.5 mg. Patients were also started on supportive treatment including proton pump inhibitors with supplements like cholecalciferol and methylcobalamin. Patient was called for regular follow-up. For purpose of presentation, we will describe the follow-up into 1, 3rd and 6th month. In the first month, patient reported improvement in severity of dysphagia from swallowing liquid only to some solid food. Dietary improvement was noted, in which she was able to take liquids like fruit juice, tea and coffee in the first month, and in the 6th month she was able to take chapati, breads and rice. Each TAN score that we have discussed earlier improved to 3 in the 6th month follow-up, and overall weight gain of 5 kg in the 6th month was assessed. Each score improved to 3. Now we like to introduce the house with the 3-stage or the biopsychosocial assessment, which is practiced in family medicine, especially useful in such cases like functional dysphagia. 3-stage assessment is a biopsychosocial patient-centered framework that systematically organizes information into 3 aspects, that is clinical, psychological and contextual stages. It facilitates the holistic care by understanding the patient illness and it plays a complex interplay of all the three factors which contribute to person illness. Biomedical system, in which we have seen patient was having difficulty in swallowing, poor sleep, chronic stressors, no red flag, family history of aggression and no organic cause. Psychological assessment, in which we have seen anger burst out, impulsivity, low frustration tolerance, coping mechanism, lack of empathy. And in the social assessment, these symptoms and signs, including strained relationship with husband and in-laws, regular family conflicts, reinforcements and avoidance of eating in public. These symptoms and signs were never addressed before, and our family members used to take this behavior as normal, which reinforced the symptoms. This model shows a complex interplay of biomedical, psychological and social factors which contributed to somatic features in this patient, like dysphagia, which help us in integrated diagnosis of functional dysphagia, intermittent exposure disorder and cluster B personality, and management of patient integratedly. We have started the patient on counseling and psychotherapy with dialectical behavioral therapy, family counseling, pharmacotherapy and dietary advice. Let's see after 6 months in what all domain patient improved. In biomedical assessment, dysphagia improved from EAT score from 18 to 3, weight gain of 5 kilograms, sleep improved, improved levels of vitamin D3 and B12. In the psychological assessment, she developed the insight and empathy, learning emotional control, anger burst out episodes decreased, and she have now positive attitude towards the life. And in social assessment, relationship with the husband and in-laws were in the improving way, better emotional bonding with the child, and she is now learning to adjust socially. Now we'd like to invite Dr. Shalini ma'am to conclude the case.
So after the diagnosis, the importance of why this case is worth talking is not because of the diagnosis. It is important how we approached the case, the stepwise approach, first ruling out the organic causes, and then only a person or a patient can be diagnosed with functional dysphagia. So let's learn today what is functional dysphagia. It is a sensation of food sticking in the esophagus, as already told, and meet the room 4 criteria. It is a disorder of the gut-brain interaction which is known as DGBI, and functional dysphagia is the least prevalent among all the DGBIs. There is rational and lack of knowledge among the healthcare workers and very limited literature available about this disorder, with an international prevalence of 2 to 4% reported, and most of the cases are underdiagnosed or overlooked. There is no basic clear understanding of the pathophysiology. However, few are postulated, like central sensitization and hypervigilance, localized hormonal dysregulation, subtle and undetectable motility abnormalities, and peripheral neural overactivation. The most important part is the management. Once the diagnosis is made, the important part in our case was the management, which was an integrated approach from the psychology department and the pharmacotherapy, which not only helped the patient overcome the dysphagia, but also in the psychological and the social aspects. Previously, she was not able to go and dine socially. Now she is able to do that. She was not able to take solids. She was not able to enjoy the pleasure of eating, which we all do. Now she is able to do that. So that's how this case makes it important.
So can I ask, how frequent is it for the patient with a functional disorder to lose weight and have, just as she had vitamin B12 deficiency, that would point towards organic disorder rather than a functional disorder? Am I right?
So, sir, this coming to vitamin B12 deficiency, we are seeing in almost normal patients also. So, I don't think this was due to this functional, and luckily this patient didn't have the severe malnutrition. The albumin and all were normal, but there are cases reported in the literature where the patient has severe malnutrition secondary to the functional disorders. And most of the cases, as I was going through the literature, in the psychiatry and the annals of esophagus, the gastroenterology journals, they report that there is a significant association of functional dysphagia with the psychiatric disorders, majorly the major depressive disorder, generalized anxiety disorder, chronic fatigue syndrome, and also even the intermittent explosive disorder is associated with GRD. However, the association with functional dysphagia is the least reported one. So my take-home message to the house today is that functional dysphagia is an underdiagnosed and difficult to treat condition that negatively impacts the lives of those affected. Pathophysiology is not fully understood. It is a diagnosis exclusion, and management involves the establishment of a strong patient-provider relationship and a multifaceted approach. Research specific to this patient population is limited, and much of what directs clinical practice is from the similar disorders of gut-brain disorders. So I would like to thank now Emeritus Chairperson Sir, Chairperson cum Chancellor Sir, Vice Chancellor Sir, Pro Vice Chancellor Sir, Principal and Controller, respected Senior Faculty Members, CCR Core Committee and Review Committee, Department of Medical Gastroenterology, Clinical Psychology, Radiology, Nursing officers and other staff, and most importantly, patient and her family. Thank you once again.